All right. Welcome everyone to tonight's workshop, Healing, Harm, or Both, the intersection of medical sequelae and GL1P use with eating disorders. My name is Danny Gillity, and I'm the Executive Director here at the Eating Disorder Foundation, and I'm so thrilled to be here with you tonight. Today's workshop is brought to you in collaboration with the Eating Disorder Foundation and Within. A huge thanks to Within for their partnership and support. The Eating Disorder Foundation was founded in 2003 with a mission to be an effective resource in the prevention and elimination of eating disorders through free and accessible education, support, and advocacy. We are a Denver-based foundation that is now serving individuals and families across the country. If you are interested in learning more, I'll be putting our website in the chat. And a few housekeeping rules before we get started. Please ensure that you stay on mute so the recording can run smoothly. And please use the chat feature to submit questions. The chat will be kept confidential, and I'll be relaying the questions to our presenters during the Q&A. And now I'd like to introduce Mandy Rector, Within's Director of Clinical Outreach, to share a bit about Within and introduce our presenters. Thank you so much.
Thank you so much, Danny. It's so lovely to be here, and hello to all of you who joined us tonight. We're really amazing, and it's a huge honor for us to be able to be a resource to our community, and big fan of the Eating Disorder Foundation. So thank you, Danny, and your team for everything that you do for our community. I work at Within Health, and I'm really excited to share more about it. And so I'll leave my we'll share my information if anybody has questions to learn a bit more later, but we are an intentionally remote PHP and IOP program treating 13 and up, and we are licensed in 39 states, plus Washington, D.C. And we have an incredible program, which I'm very, very excited to share fun facts with you all about, but I want to kind of shine a spotlight on our lovely presenters who are joining us this evening. I'm excited to have Chrissy Stockert, who's our Chief Health Officer, and Sean Reibel, who's our Chief Nutrition Officer with us, who's going to be doing this really interesting and engaging presentation. So I'm going to turn it over to Chrissy to introduce herself, and we'll get the presentation started. Thank you so much for being here.
Well, hi, everyone. Good evening, or maybe not evening quite yet. I'm coming to you from bright and sunny Miami, Florida. So it is 7 o'clock for me, but I know lots of people are coming from different places. So welcome. We're so happy to have you here. Thanks, Mandy, for introducing us. Like she said, I'm Chrissy Stockert. I'm the Chief Health Officer at Within Health. I'm also a nurse, been working in the eating disorder field for over 15 years now, and love being here every day, and I'm really excited to be here to bring this topic to you tonight. And I'll toss it over to Sean.
Thank you, Chrissy. Yes, my name is Dr. Sean Reibel. I'm the Chief Nutrition Officer at Within, like Mandy mentioned. I'm a dietitian by trade, and I've been in the field for some time. I started doing research actually at UCCS, so down south from EDF, Denver, with male cyclists, subclinical eating disorders in male cyclists. But we're excited to have some time with you guys tonight. I'm zooming in from Florida just for context as well. So yeah, it's 7 o'clock and sunny here as well, not to rub it in for anybody else, but we'll just keep it at that. How about that? No temperatures or nothing will be shared tonight. Chrissy, do you want me to go to the next one, do the learning objectives? So I know.
Sure, absolutely.
Thank you, Danny, for the introduction with the title. Our hope today for y'all, and we'll get into the objectives in a second, and hopefully our hope, Chrissy and I's hope, is that we're going to be volleying it back and forth with things. The one thing that we did want to say from the outset of this is, hey, like, we're coming to this knowing that each one of the things that we're going to discuss related to eating disorder, medical complications, the way that GLP-1s might interact with some of these complications, they could be talks in and of themselves. So we just want to put that out there first and foremost. We're going to try to do our best at providing a comprehensive overview of things, but this can just be like the tip of the iceberg. If there's more information that you're looking for, I know Chrissy and I would be more than happy to share resources with you. We have references at the end, and our email addresses are at the end as well. But today, what we're hoping is that at the end of this talk, you'll be able to name 2 body systems affected by medical complications of eating disorders, describe the medical consequences of eating disorders, so specifically what happens when you have this disordered eating behaviors and symptoms, and how that affects the body, and then also the medical complications of eating disorders that can perhaps be worsened with GLP-1 receptor agonists, but also too where the research goes and like harmful, helpful, kind of looking at those things. And so we'll dive into all this.
All right. So we are going to go ahead and jump right in with what is happening to a body when it has an eating disorder. And one of the main things to know is that at the end of the day, every single body system can be affected by an eating disorder. When we're talking about eating disorders, we are looking at energy in and energy out. If energy in is insufficient, the body will do whatever it can to decrease the energy out. And it does that by shutting down different systems throughout the body. So we can see the GI system be affected. We can see the liver, we can see the kidneys and bladder, we can see the pancreas be affected, the heart and blood vessels, bones and muscles, the brain, the skin, the reproductive system, our endocrine system in general. And we will not have time to talk about all of that. We could talk about each and every one of those individual topics for hours on end. So you're going to get the Cliff's Notes version of a couple of different body systems. And then one of the biggest hot topics in eating disorders is the GLP-1s and how those then interplay with these medical consequences associated with eating disorders. And so we're going to look at how those meet.
Well, and so when we're talking about GLP-1s, what does that mean? Well, a GLP-1 is glucagon-like peptide 1. Now, this might be basic for some people, it might be new for others, but we wanted to make sure everybody understood what we were talking about with this. We're all on the same page, right? So GLP-1, it's an incretin. It's secreted by the last part of the small intestine and the beginning part of the colon, specifically from cells that are called L cells, okay? So whenever we eat this incretin, which is a hormone, it's a gastric polypeptide, and I know I'm using a big word, but a polypeptide is just a hormone. It's made up of many different amino acid chains, okay? So that's why it's many polypeptides. Peptides are those amino acid chains, okay? But they create a decrease. This is GLP-1. Once it's in the body, it causes a decrease in blood sugar after you eat, okay? The main takeaway is that GLP-1, it's a hormone that causes your body to control blood sugar by stimulating the beta cells of your pancreas to release insulin. When insulin is released, then blood sugar will decrease, okay? When we're talking about agonists, we say, okay, what's a GLP-1 receptor agonist? Well, an agonist is a drug or a substance that binds to a receptor site, and that's what you see in this slide, on this schematic on the bottom right of your slide. It binds to a receptor on a cell or a cell surface, and it causes the same action as that specific substance that's supposed to bind there. So this receptor agonist, these drugs that we talk about, they bind to that site, okay? Now, as a disclaimer, when we're talking about GLP-1s today, it's the easy way out for us. We're taking the easy way out because we're talking about a whole spectrum of medications here. It's kind of like when you talk about Kleenex or Band-Aids, right? You know I'm talking about a tissue or a bandage, right? So when we're talking about GLP-1 RAs, we're talking about the whole spectrum of medications. And what I mean by that is some of, more of the names that you would hear are Ozempic, Wegovy, Victoza, or Sandexa, but that's semaglutide, okay? And you also have other ones that are called Zepbound or Mounjaro, and that's trizepatide. And the thing that I wanted to highlight with this is that while we're calling it a GLP-1, these drugs, specifically, like I just mentioned, trizepatide or Zepbound, these drugs, they're dual agonists. So what it means is that they're not only hitting on that GLP, but they also might be hitting on GIP, gastric inhibitory polypeptide. They might be hitting on that, or others, a more recent one that's in experimental trials called retatrutide. I'm going to try it. I'm not going to mess it up, but anyway, there's one that's experimental, but it's a triple agonist that's GLP, GIP, as well as glucagon. So I just wanted to make sure that you guys got that when we're saying this. It's this whole spectrum of drugs, and we're kind of just trying to nail it down to this one word here. The thing that I also want to highlight is that these drugs, these receptor agonist drugs, they're not new, okay? They've been around on the market for about 17 years. The long-acting ones, about 15 years or so. The studies have been done since about 2018 on those dual agonists as well. And so we just wanted you guys to have that basis there. Chrissy, I'm gonna go to the next slide. Thank you. And so what do these drugs do? What do we know, right? And you guys, you might be able to chime in and say, and you know, like, oh my God, what you hear in media about these drugs. But mostly these GLP-1 receptor agonists, they're known to create a decrease in body weight. There's research that shows, we'll get into further, well, hopefully a little more further detail about cardiovascular benefits. So decreasing blood pressure, decreasing blood glucose, impacting triglycerides and other metabolic parameters. But you could see here how they play a role. They have receptors all over the body, specifically when you're thinking about that, okay? So they're in the kidney, they're in the pancreas, they're in the brain as well. So that's going to affect appetite. That's going to affect that drive to eat when we're talking about the GI system. We'll get to that too. So please know that you could see those GLP-1 receptor agonists, they are known to affect many different areas of the body because of where those receptors lie. And so with that, I'm going to turn it over to Chrissy to one of the main body systems that we're going to hit on tonight, the GI system.
Absolutely. So when we're talking about the GI system, if the body is in a state of malnourishment, the GI system is going to want to hold everything in. And when it does that, it's going to slow things down, and that can cause a host of problems from top to bottom. So fun fact, our GI system, we're talking about anything from our mouth down to where it comes out. And here's the fun fact part about it. Our GI system is actually considered an external part of our body because it goes from one open hole to another open hole. So it's actually external and not internal, though we call it an internal organ. So our GI system, it is everything from chewing to swallowing to getting acid thrown into the food that we've eaten in our stomach, into the small intestine where food, nutrients, vitamins, everything is absorbed, and then into our large intestine where water is absorbed until it comes out. When someone has an eating disorder, every single piece of the GI system can be affected. We can see swelling in the parotid glands. We can see tooth erosion that happens if someone is engaging in purging. One of the main things that we see with eating disorders is acid reflux. So the way that things are supposed to work is when I swallow, a bolus of food will go down my esophagus. I have a sphincter at the bottom of my esophagus that will open up, let the food into my stomach, and then close up and be a very tight seal. Because in my stomach, hydrochloric acid is going to be released. And we've all heard of hydrochloric acid. It's a very strong acid, and its job is to break down food. If that sphincter becomes loose, acid will be able to free flow up and down. With eating disorders, we see this commonly in someone who engages in purging behaviors. The food is going down, it's coming back up, it's going down, coming back up, and that sphincter will loosen. We also see it when someone is malnourished in general because of weakening muscles. So we see this acid reflux as a very common side effect or complication of eating disorders that can lead to inflammation in the esophagus, ulcers. Ultimately, it can lead to Barrett's esophagus, which is a precancerous change that happens in the lining of the esophagus. It's a precursor to esophageal cancer. and not something that we want people to be dealing with on a regular basis. So we treat it with Tums, we treat it with H2 blockers, things like Pepcid. We'll treat it with PPIs, Nexium, Protonics, things like that, because we want to make sure acid can be well controlled so that there aren't long-term ramifications to that reflux.
Chrissy, before you go on, just want to let you know, need to advance the slide. This one.
Oh my gosh, I'm so sorry.
It's okay. It's okay. I
There
know
we go.
you went into the acid reflux, and I
I
know.
sure did.
But so
Sorry
y'all,
about
yeah,
that.
your
Y'all didn't get to
Chrissy's
see my
summary is
pretty
there.
picture of lines that I have. The next thing that we can see is something called gastroparesis. So gastro meaning that GI system, paresis meaning stopping or a slowing of the GI system. The reason that the GI system is going to slow down is that it wants time to absorb all of the food that it has the opportunity and all of the nutrients that it can before it's excreted from the body. So we can see slow gastric emptying with this, where someone eats something and feels full immediately because it feels like that food is just sitting in the same spot for a long period of time. We can see that lead to nausea. We can see it lead to vomiting. We can see it lead to bloating, abdominal pain, changes in blood sugar levels. When someone has gastroparesis, they're going to be more prone to hypoglycemia. So a lot of people hear about hyperglycemia, or high blood glucose levels, specifically related to diabetes. When the eating disorder realm, we often see hypoglycemia and see individuals with low blood sugar. We also see with eating disorders a whole lot of constipation. So that GI system has slowed down. We need it to speed back up again, but there's nothing we can do to talk our belly into speeding up again. It needs to trust us again. So once someone reintroduces food, it can take a long time for things to speed back up to normal. And so we'll see often sometimes people going 6 or 7 days without having a bowel movement. That is not comfortable. We see the complications that can be associated with that. We see hemorrhoids, fecal impaction, rectal prolapse, all those different things that can happen due to the straining that they have to do. We see increased laxative use, which can be very dangerous, especially if someone is using a stimulant laxative. And so we want to make sure that when we're treating eating disorders, we're aware of all of these different pieces. And then as I throw it back to Sean, now we're introducing the idea of a GLP-1, which can cause which of the following, Sean?
Thank you. Great segue there, right? And so when you do throw that GLP-1 in, what happens, right? So when you look at studies, research actually shows that when some of these are used, so you have semaglutide and liraglutide. Liraglutide is Victoza and Sandexa. When used specifically for weight loss without diabetes, there were increased risk for pancreatitis, bowel obstruction, and gastroparesis. And that's what you see on the right-hand side of this slide here. But when you dive deeper into the literature, when you see all the adverse effects that come from using these drugs, these classes of drugs, the main ones that you see are nausea, diarrhea, constipation, and vomiting. Anecdotally, we've seen more of that nausea and constipation more than anything else. For statistic wise, if you're wondering like, okay, well, how much, Sean? What does that mean? Like, if you're saying, okay, it's in clinical trials. Well, what we see is anywhere from 40 to 70% of individuals on these drugs developing some sort of adverse event or reaction there. Okay, we can dive into the nitty gritty of that, but the main point is that these symptoms, these effects that are happening are pretty prevalent there. So when we think of what's happening there with the GLP-1s, well, they act on the stomach. They slow down gastric emptying. It's basically inducing gastroparesis, something that Christy and I didn't talk about, and I'm just thinking of it right now. When we, years ago, when we were talking about how gastric bypass was introduced in the eating disorder world, right? Like not introduced, but when it was used, and some of the language that I heard in my training, people are like, man, you're actually providing like an amputation of the body. And it's like, well, you're creating this issue, right? And that's with the GLP-1, you're actually slowing down the GI tract, which what Chrissy mentioned, what happens with eating disorders, right? Like even if we're not talking about the just restrictive eating disorders, we're talking about binging as well, because that typically comes in these patterns of, okay, I'm eating, no eating, eating, no eating. So you're going to have these times where the body gets triggered and those responses happen. Now, Chrissy was talking about acid reflux and that esophageal sphincter as well. Well, if you're having a slowed gastric emptying time, which is gastroparesis, well, I know medically it's different when you think of it, but slowing down, there's going to be more of that risk of acid coming up. So that's something that we have to think of there. Again, the constipation from slowing down, things aren't moving in, so you can get impacted with it. The early satiety as well, that's something that comes in when you think of, okay, when we're in treatment for an eating disorder, one of the ways we have nutrition rehabilitation is helping our bodies recognize, okay, I'm not going to go through feast or famine. I'm going to have food consistently. My body can rely on that. But if you have that early satiety and that slowed gastric emptying, that's going to be problematic even more than just the eating disorder there with these GLP-1s. The thing that we wanted to highlight with this takeaway, if someone's already experiencing these symptoms with an eating disorder, the reflux from perhaps the repeated purging episodes, or even just in general, if it's genetic, something there, if you have that slowed transit time, that's going to be amplified by taking one of these medications. Okay. Chrissy, I'll pass it back to you so we can move on to bone health, unless there was something else you wanted to put up.
All right. No. Bone health. So I love talking about the bones. I'm really excited about this. I'm not going to forget to switch my slide right now. So bones throughout the lifetime. Every 10 years, we have an entirely new skeleton. I love saying that. I am in my mid-40s. I am currently creating my 5th skeleton. I am very proud of my 5th skeleton because throughout our life, we are in a constant state of overturning bone. We want it to be fresh so it can be nice and strong and not brittle. So we are depositing bone and we are recalling bone. When we're young, we should be depositing a lot more bone than we're recalling. So our bones are getting bigger and thicker and stronger. The peak time of bone formation is in adolescence, right around puberty. It's going to be very high until we're about somewhere between 25 and 30 years old. At that point, we end up in a state of equality. We are depositing bone, we are recalling bone, and it is in equal amounts. Our bones are their biggest, thickest, and strongest. Once an individual who has ovaries goes through that menopausal transition, estrogen will go away. Estrogen is the hormone that drives bone formation. And many of those individuals will end up in a negative bone state. So they are depositing bone and they are recalling bone, but they are recalling more than they are depositing. And they end up with less and less bone, which is what ultimately leads to the diagnoses that I'm sure a lot of you have heard of, osteopenia and osteoporosis. For an individual with testes, testosterone ends up having similar effects, but tends to decrease later in life, but you can still see the same pattern of lots of bone deposition, and then it starts to decrease later on in life. And so that is how bones should work throughout the lifetime. But one of the things that we see is that with eating disorders, bone loss happens. And so it's happening to individuals who are much, much younger. And so one of the statistics that we have is that 30% of people with anorexia have osteoporosis, which is considered irreversible bone loss, and 90% have some bone loss. So bone loss happens. It's just a matter of time. And so one of the things that we do is we will often have somebody get what's called a DEXA scan. And we get this for almost every individual that comes through our doors, because what we are seeing is that though this research and this fact that I have here is specifically related to a study that was done on anorexia, we see bone loss happening throughout the spectrum of all eating disorders. It used to be, oh, only someone who is low weight, and has been malnourished for a prolonged period of time is at risk for bone loss. And that is not true. We see it in people with anorexia, bulimia, binge eating disorder, ARFID, atypical anorexia, any of the OSFED diagnoses. We see it with all of them. We see that their Z-scores and T-scores are well into the negative numbers. But one of the things that we've also seen is that where bone loss used to be considered an irreversible diagnosis, we're seeing that it no longer is. So that's why they've actually, in younger individuals, taken away the diagnosis of osteopenia and osteoporosis. And now they give you a diagnosis of less than expected bone mineral density. That's how it's typically worded these days. Because we know that with recovery from an eating disorder and time, you can see people making up some of what's been lost. It is no longer totally irreversible. Someone who has a high level of bone loss may never get back to 100%, but if they fully recover from their eating disorder, we see that they are able to make up some of what they've lost. So then the question becomes, how does a GLP-1 fit into this? And one of the things, Sean, before I toss it back over to you, is that I want to say is that the patients that we have that may be coming into practices that you are a part of are all doing their own research. They are all going to Dr. Google and they are wanting to know about these things. And so what we're going to show you here is what you can find by quick Google searches, because we need to know what they're seeing. So we can know how to then interpret that and make sure that we are giving people the best information possible. So Sean, go for it.
Yeah, I'll go for it. Okay. Well, like what Chrissy said, so Chrissy and I, when we were preparing for this talk, we were both looking into the bone health, and we happened to be in a meeting together. And Chrissy's like, "Oh my goodness, look at this! Look what I found with this! Like, there's actually some beneficials on this." And I was like, "Wait, Chrissy, I just found the exact opposite right here! Like, this is hilarious." So we wanted to highlight that. And the main thing that you could see with these two studies again, and you could dive into them more, is that we need to again know what clients are seeing and also inform ourselves. So some research shows that GLP-1s, these drugs are going to have a protective factor, while other research, it doesn't. We know for a fact that when someone isn't eating enough, or someone's not eating consistently, or not getting enough variety, that will affect bone health over time. So with our patients that are experiencing eating disorder symptoms, right, we want to be able to first treat the eating disorder, because we see bone loss, or at least that risk of that bone loss developing in all types of eating disorders, okay? And that's across the board, whether it be a restrictive eating disorder like anorexia or binge eating disorder. Now, the thing that we have to highlight though too is that what does help? Well, you could see here in this example one, weight-bearing exercise, resistance training, right, with that movement. So those are things that we can highlight for clients, but also that might help the client understand, okay, wait, this is why healing my relationship with my body and with movement is so vital to my recovery, because I ultimately want to be able to do X, Y, and Z. I want to be able to travel to Europe. I want to be able to travel down to Florida and visit Chrissy and myself, right? But in all honesty, it's to help that client see, oh, wow, okay, this doesn't have to be something that is rigid or militant or however it's been framed before, but something that I can hopefully embrace over time. Chrissy, did you want to add anything to that one?
Yeah, I think we're good.
Okay. Well, with that said, we'll move on to the next system, thinking about cardiovascular health, thinking about the heart and the vasculature.
All right. So when it comes to eating disorders, there are so many cardiovascular complications. I don't have time to get into all of them right now. When it comes to the GLP-1s, there is a strong association between their use and the lowering of blood pressure. So that's what I'm going to look at today when we're talking about eating disorder and complications that we see with it. So when we're talking about blood pressure, in case you don't know these pieces already, we have two numbers. We've got a top number and our bottom number. The top number is called your systolic. The bottom number is your diastolic. The systolic blood pressure is the amount of pressure it takes to pump blood out of your heart to get that valve to open and shoot that blood into your arteries before it closes. The bottom number, the diastolic, is the amount of pressure that's left in your heart when your heart is at rest. So if you talk to a cardiologist, they're very concerned about your diastolic number. What does it look like when your heart is at rest? When we are talking about eating disorders, we are very concerned about that systolic number, because for our population, typically we're looking to make sure that that blood pressure is not too low, because low blood pressure can cause a host of issues that make people really not feel good. When someone is being checked for their eating disorder medically, we always ask for orthostatic vitals. If you do true orthostatics, you're looking at a lying blood pressure and heart rate, then a sitting one a couple minutes later, then a standing one a couple minutes later. Often we go through it a little more quickly than that. We do a sitting and we do a standing. And we're looking to see what happens to those numbers when someone goes from sitting to standing. When someone is sitting, their blood is in a certain position. When you stand up, gravity takes over and blood is going to fall. That's just the natural order of things. So what our body has to do is it has to be able to compensate for that change in posture immediately, tighten up those blood vessels to keep the blood shooting upwards so that it can continue to get to our brain. If the body can't do that because it's malnourished, that blood pressure is going to drop when we stand up. And then the heart is going to go, oh my gosh, I've got to compensate for this. Maybe I can compensate for it by beating really fast. And so I can still get blood up to the brain. And so you see a drop in blood pressure and or an increase in heart rate. And that is when someone is orthostatic. And there are specific numbers tied to it. But what you need to know is, does your blood pressure drop? Does your heart rate spike when you go from sitting to standing? With eating disorders, we see this all the time. And very often someone is coming in with a low blood pressure to begin with. And then when they stand up, all of a sudden the symptoms start. So we've all probably stood up too fast and gone, woo, I just got a little bit dizzy. And then it goes away about 10 seconds later. When we're talking about someone with an eating disorder, though, it very often happens that they stand up, they feel really dizzy. It lasts for a couple of minutes. Maybe they need to sit back down. They need to grab a wall. They need to brace themselves. They might black out. They might actually feel a lot of pressure in their head. They may faint. They may fall. All of those things are things that we see in this eating disorder population, because there may be a low baseline blood pressure that then gets even lower when they stand up. So now we throw in a GLP-1. And what do we see, Sean?
And what happens, right? And then what happens, right? So what's the good news, y'all, right? What's the good news? Well, so let's think through what Chrissy was saying, right? Well, thinking through, well, she mentioned about what happens in your vasculature, how things need to tighten up and the heart rate and your heart needs to compensate for that too. Well, if you look at GLP-1 receptors, they're found in the hypothalamus, also in the brainstem, as well as the carotid body. The carotid body, you guys might have heard of the carotid artery, right? And where that branches, that's called the carotid body, okay? So we can say that GLP-1 receptors are found in the vasculature and also the kidneys. Now, if you think about it, when you think of those areas of the brain and those areas in our bodies, those are the areas that are primarily responsible for blood pressure, right? Of regulating blood pressure. So that's where some of the theory and some of the studies have been on of like, okay, how is this working and how is this helping out with blood pressure, okay? So what happens is that if there's a shift in the brain, if there's a shift in the body, it sends the signal to the brain, and then the brain adapts to create this create homeostasis. And so what Christy was explaining was how the body was trying to regulate things from that. When someone stands up, the gravity's pulling blood down, right? Well, when you look at GLP-1s and when you look at meta-analyses that have been done on GLP-1s and their blood pressure lowering effects, it shows that it's thought to be cardioprotective. Okay, so what does that mean? Well, you can see a really early study in 2013 that, okay, it lowered systolic and diastolic blood pressure by 1 to 5 millimeters per mercury, all right, compared to other anti-diabetic medications. Okay, what about a more recent study? Well, a more recent study of almost 500 people found that there was a lowering effect of the systolic blood pressure by about 10 millimeters per mercury. Well, when you think of that, that's not very extensive. However, over time, how is that going to affect someone, especially if they have that sensitivity to blood pressure already because of the eating disorder, right? So those are things that we need to consider. Is that helpful or harmful for this person? We don't want to say here today, and I think we didn't mention it before, we're not going to say yay or nay about what to do with these drugs, but what do we need to consider? Right? We need to think through, okay, well, how is this going to affect this person? What's this person's history? If they have a history of having orthostatic hypotension, and we add in this GLP-1 to help with some of their perhaps blood sugar control or whatnot, how is that going to affect them? What do we need to be conscientious of? In Christy and ours environment, working at Within, it's something where we know when someone's virtual, we don't have eyes on them 24/7. So we need to be sure that we know that this person has a plan in place if this medication is included, there.
And I think about specifically when we're talking about cardiovascular, there is going to be a population where this medication may be incredibly beneficial for them. Then I think about one of our patients who comes in with atypical anorexia and lives in a larger body. They still have anorexia and they still have all of the symptoms associated with anorexia. They have all of the medical complications that go along with it, but tend to be ignored by providers when they bring up those symptoms, because providers often, not all, often will focus on weight loss for them. You're in a larger body, you've got to lose weight, and they already have low blood pressure. They already feel dizzy when they stand up. And now this is going to be prescribed to them as the magic cure-all fix-it. And now really what we're seeing is that that blood pressure is going to drop even farther. So where there may be someone who is more on a hypertensive spectrum, has higher blood pressure, where this may actually have some very beneficial effects for them. There are also those individuals that are often not seen the way that they need to be seen in the general medical population because of the size of body that they live in. And we really need to be thoughtful and careful with that. And so lastly, we're going to take a look at mood and how that's affected when it comes to eating disorders. And again, how that goes into some of the GLP-1s. So when we see individuals with eating disorders, we see anxiety, we see depression, we see OCD, we see ruminating thoughts, we see any host of other co-occurring psychiatric diagnoses that go along with the eating disorder. Specifically, when we're talking about someone who has very restrictive behaviors, one of the things that we see is an absence of serotonin. What we know about serotonin is that when serotonin is high, mood is high, anxiety is low. When we see low levels of serotonin, we see mood that's low and anxiety that's high. They go hand in hand with each other. Because serotonin is not something that our body can make by itself, it is transformed into serotonin because of food that we eat, specifically tryptophan goes through a whole process, becomes serotonin. if somebody has a highly restrictive diet, they may be lacking serotonin altogether. We would expect then to see high levels of depression, high levels of anxiety. One of the other things that we see in the brain of someone with an eating disorder is often an imbalance in dopamine. So we see patients that come in with these really intense ruminating thoughts about food, weight, body image that feels very, very flooding. It feels like it's in front of their face like this all the time and they can't get a break from it. That happens because of an imbalance in dopamine. It can be too high in some areas, too low in other areas. Please do not ask me what areas those are because I am not a psychiatrist and I do not know that. I just know that there is an imbalance in dopamine levels in different parts of the brain. And so some of the way that we treat it, first, let's work on nutrition. Sometimes we're talking about medication interventions. We're talking about the therapeutic intervention. So individual therapy, group therapy, CBT, DBT, ACT, all of the skills that people need in order to really push through the eating disorder, and using sometimes medication interventions as a way to open up the pathways to recreate neural pathways in the brain. So one study that I read showed that where dopamine is typically a pleasure neurotransmitter, we eat something, it tastes good, dopamine is released, and we feel really good afterwards. We want that more. In the brain of someone with an eating disorder, after eating, the dopamine is released and they have an anxiety response to it. So they have this misfire in the brain where the dopamine actually causes anxiety instead of pleasure. And so what we have to do is we have to work to rewire those neural pathways to allow them to feel joy, feel that happiness, feel that pleasure after eating again, instead of feeling the anxiety. And what we know is that the brain can be rewired. There is neuroplasticity. There are stem cells in our brain that can rewire. And it's not like, oh, I'm over 25 years old, can't teach an old dog new tricks. We know that you can. That this can be done, but it takes a long time and a lot of hard work with it. So we see that with eating disorders all the time. Sean, go ahead.
Can I jump in? A few people asked a few questions directly related to what you were asked or just speaking about.
Yeah.
Somebody just wanted to know if you could repeat the serotonin and correlations between the anxiety and mood.
Yeah, absolutely. So I think the easiest way to remember it is low serotonin equals depression, high anxiety. High levels are not high, but normal levels of serotonin, you're going to see lower depression, lower anxiety. So better overall mood.
Awesome. Thank you. And then one other question, can you speak for a second about the thyroid's function in all of this, if it is related or has an impact?
So the thyroid has a huge impact on everything in the body.
Yeah.
So the thyroid is really the driver of the metabolism in our body. It regulates temperature, it regulates mood, it regulates our heart rate, it regulates everything. And so when someone has an eating disorder, what we will often see is low thyroid levels. The body is saying, you're not giving me enough energy in. I'm going to lower the energy out by decreasing the output of the thyroid. And all of those functions are going to decrease. So you see things like the low heart rate, you see low core body temperature. I've seen somebody with a body temperature as low as 93 degrees. It was 93.8. I was like, no, you meant 98.3. No, it was 93.8 degrees. You see someone feeling cold all the time. You see the low circulation, all of that. The thyroid helps to kind of drive all of that. And so you'll see something called, it has a long name, it's called euthyroid sick syndrome, where you see low levels of thyroid hormone, which if someone had true hypothyroidism, you would see very high levels of something called TSH, which is thyroid stimulating hormone. The brain would be going, thyroid, why are you not working well? work better, and it throws out a ton of TSH, thyroid stimulating hormone. In someone with an eating disorder, you see low levels of thyroid hormone and a totally normal stimulating hormone level. It's not trying to stimulate the thyroid anymore. But a lot of people end up put on things like Synthroid to try to speed up their thyroid function when all they actually need is nutrition. So that's a quick and dirty way of talking about the thyroid.
Love that. Thank you, Chrissy. It's always such a pleasure to have you explaining all this stuff. It's so cool. With the mood stuff, so Chrissy explained the differences that we're seeing with the brain, with the different neurochemicals and whatnot. But we were also thinking of like, okay, well, how much is this affecting people, right? So what you could see, 94% of people, and this is in some research there, 94% of people with eating disorders have a co-occurring mental health condition. Okay, so when you think of that, what does that mean for those different conditions, and how is that affected, right? How's that affected by this GLP-1 medication too? Well, what we know is that about 50 to 80% of individuals with eating disorders are known to have anxiety. About 60% of people with eating disorders have OCD, okay? Then when you think of depression or major depressive disorder, there's about 30 to 50% of individuals with eating disorders have major depressive disorder. And that's with, when you're looking at anorexia, bulimia, or binge eating disorder. Then if you think of stress, of post-traumatic stress disorder, 38 to 44% of people. Then also with substance use disorder as well, that's 35% of individuals with substance use disorder have an eating disorder specifically. And that's even higher than what the general population is. So if we're thinking that if we know that these mental health conditions are things that someone with an eating disorder is experiencing, what happens when you throw a GLP-1 on them, right? So what we do know is that GLP-1s, it's thought to have both a peripheral, which meaning the outside of the outside the central nervous system. So GLP-1s have a peripheral and a central mechanism that helps with mediating food intake. Okay, so when we think of that, it's like, okay, so it's hitting some brain chemicals at some point, right, centrally. So how does that happen? Well, centrally, those GLP-1 receptors are in the hypothalamus. So they reduce food intake by acting on, thinking of, okay, I have enough energy. Let me, if we have the slow gastric emptying, it continues to send that message to the brain. Okay, I still have food. I'm good. I don't need more food, right? Okay. Whereas the other mechanism in the amygdala, okay, the amygdala is like the fire alarm of the brain that reduces food intake by symptoms of stress. Okay, so when we're thinking of that, okay, anxiety, if so many people have anxiety, up to 80% of someone with an eating disorder has anxiety, how is that GLP-1 going to affect it? Right. Well, the other thing we have to think about with these GLP-1s is the gut-brain microbiota access as well. We see that how the our gut microbiota have such an effect on our brain, and there's that continually cross communication happening as well. Okay, so we can't really ignore the fact that these drugs that are going to be sending different signals to our brains through the gut, whether that be through ghrelin or leptin or peptide YY, these gut hormones that show us, okay, hey, you've had enough food or you haven't had enough food, those are going to be affected not only by the literal slowing down of our gastrointestinal tract with the drugs, but then throw on the whole thing with the eating disorder as well. We see that happening constantly. So okay, what about anxiety, right? Well, what we know is that anxiety is can actually be kind of helped out a little bit with anxiety. It can be decreased with a GLP-1. Okay, so there was significantly decreased anxiety in some studies. Then if you look at other studies, it shows that anxiety actually increases, which makes sense when we think of that amygdala, the way that it's hitting one of those brain regions there. But the thing that Chrissy, I'm going to let you hear, you did this one. So you want to go into it, the harms with the study, because you found this one. I found this fascinating.
Yeah. So, when we look at the research, and again, this goes back to people that are coming in having done their own research. And if you look up GLP-1 can it help with anxiety, scholarly articles. You're going to find something that says something like this. This population-based study demonstrated that recipients of GLP-1 RA treatment for DM were at a significantly decreased risk of anxiety. However, the effectiveness was significant only for female users and patients using the medicine for longer than 180 days. The treatment effectiveness was moderate in reducing depression risk, especially for patients that used dual glutide. These findings strengthen previous research advocating the antidepressant and anxiolytic effects of GLP-1 RAs. Amazing. That sounds fantastic. Now, if you Google GLP-1s increase anxiety scholarly articles, something like that, you're going to find this. This study showed a significant association between GLP-1 RA treatment and a 98% increased risk of any psychiatric disorders. Notably, patients on GLP-1 RAs exhibited a 195% higher risk of major depression, a 108% increased risk for anxiety, and a 106% elevated risk for suicidal behavior. Now, we don't necessarily know the study size. We don't know what the starting number was to show 106 or 195% increase. You know, there are limitations to all of this, but you can find both no matter what. You can see, absolutely take this. This is going to help so much, or do not do this. It's going to harm you. What do we do? I don't know.
And that's, I was just going to say,
ahead,
and it's the same with depression. If you look at depression, there are some things though that show that there are increased risks of depression, but there are helpful, beneficial effects of GLP-1s with depression. Specifically, why though? Why is that happening? Well, one of the theories is when you think of neuroinflammation, it's thought that through its mechanism centrally going through the brain, that GLP-1 receptor agonists improve the responses to neuroinflammation, specifically cytokines. So cytokines are basically immune system responses that play a role with inflammation. You guys might have heard of interleukin or tumor necrosis factor. You might not have. You might be like, what is that? And that's okay. Don't worry. The point is that they play a role in that inflammatory response. So it's thought that when you have that neuroinflammation, which is going to kind of contribute to some of those factors being present in the brain, okay, that's a depressed brain. That's what it's called in literature. It's okay, that's a depressed brain. So with this GLP-1, if it's helping modulate the production of some of these cytokines, then you're good. It's going to help reduce that depression there. I want to be mindful of time, but we can't ignore the fact of SI and SH. If you look at the European Medicine Association, I think that's the correct term of it, but they've actually put out notices about the increase in suicidality, and there have been reports of self-harm. So we can't ignore the correlations that we're seeing there, but more research is needed for how we look at these medications and how we also consider them when co-occurring with an eating disorder and these other conditions as well. So in conclusion, what we know eating disorders affect multiple body systems. The GLP-1 receptors are located centrally and peripherally. The research shows that those GLP-1 receptor agonists, they can have an effect on those multiple body systems that are affected by eating disorders as well. Something that we do not want to overlook is that we have to consider the risks and benefits on the past, present, and what might be coming in the future for individuals. Y'all, if there was a recent New York Times article about how these drugs affect individuals' social lives, specifically around their intimacy with their partners. We can't ignore those things with these medications. We're going to see them more and more. And Chrissy and I had a fruitful conversation earlier today, just even talking, and Chrissy, I'm going to turn it over to you with that. But I wanted to say we need to consider the risks and benefits, and that things aren't always going to be the extremes. It's not going to be black or white. It's not going to be, okay, I definitely see that this is good or not good. There's nuance. We need to know about the drugs, and we need to know what our clients and what our patients are looking at, and we have to know how the impact, how these drugs are going to impact people's circumstances.
I think that at the end of the day, we need to make sure that I'm not a prescriber, Sean is not a prescriber, that the prescriber is really evaluating the whole person and not one aspect of that individual. There are going to be times when this is indicated. There are times when, I know a year ago in the eating disorder world, or 2 years ago, it was like, no, the GLP-1s, ah. And now it's changing. That's not the mentality anymore. We know more about them. There are times when they will be indicated, and there are times when they will not. We need to make sure that an eating disorder is being treated. And there may be an indication for someone that this may be actually really beneficial for them, and we want to try it as a modality in conjunction with treatment for the rest of their eating disorder. I know we have whopping 3 minutes for questions, but if anybody has any, or Danny, if anybody has sent in anything.
Yes, thank you both so much. That was amazing and so informative. And I just want to say, if we don't get to your question, Mandy put her email, or I sent you Mandy's email in the beginning of the presentation. So please email her or reach out to me directly. I'll put my email and we can continue this conversation after this evening. But someone asked that they say they've previously heard that GLP-1s for weight loss were not tested on individuals taking an SSRI. Curious if either of you know anything about this or can comment on that.
I personally haven't seen much about the co-occurring use of some of those SSRIs and GLP-1s. Chrissy, did you have anything?
I haven't seen research on it, though I can say anecdotally, I have seen a lot of people using it in conjunction with other medications. So, there are a lot of, for example, individuals going through menopause and perimenopause where they have really big mood changes and they have associated weight gain, and you have SSRIs, SNRIs being prescribed right alongside the GLP-1s and are being used safely that way.
Yeah, okay, thank you. Someone wanted to know, back to the very beginning of the presentation, you mentioned that Within has a practice of getting everybody a DEXA scan, and they were really curious if that was just your practice across the board or what you do. A little bit more about that, how you treat clients with that.
Yeah, so, I will say it's not 100% of patients,
Okay.
but it is something that we recommend very often in a broader way than you would typically see, where someone would say, oh, if they've had amenorrhea for 6 months, then it would be a DEXA scan as indicated, because we have seen so many instances of individuals who have never had amenorrhea and have bone loss. We have individuals who have never been diagnosed with anorexia, but have bone loss. And so we think that it's something that needs to be done on a much wider scale. And if we can have insurance cover it, then we want to get a baseline, because we also want to see what's happening in 2 years, in 5 years. If you've been in solid recovery and you had some bone loss, 2 years later, we want to see if that's improved. And we have seen that improvement. We have seen people who had a Z-score or T-score of -2, and now it's -1. So we've seen that improvement, and then, it gives people hope.
Yeah.
Yeah.
Thank you so much for that. And then we'll end with this question, but again, please reach out if there are questions we didn't get to. So you all spoke about GLP-1s and their effect on the GI system. They said you spoke about this regarding the medicine semaglutide, but what about with Zepbound and that category? Is there a difference?
So that research is still coming out. And so when you look at Zepbound and trizepatide, and specifically those what are
The GLP-GIPs.
Yeah. So just all those are the dual and triple agonists. they are all in that meta-analysis. They were looking at that. The research is still coming out though, so it's changing, and that's the thing that's really exciting about this, but also something that's kind of exhausting. You have to be on top of it. But for Zepbound and trizepatide, yes, there were still some of those adverse effects reported. I know that there has been some publicity about decreased incidence of that, but I haven't seen that consistently in the literature. What you do read about is that it's more of the timing and when they're making the dose adjustments, but you can't get around that those side effects are going to be part of that process, and they might change from person to person. Scary instance with someone that did not, this is someone that I knew does not have this, well, has disordered eating, not an eating disorder, started taking semaglutide, and I know this isn't Zepbound, and had serious effects, had an obstruction, had to go to the hospital within 7 days. I mean, transparently, individuals on my family, I found out, are taking trizepatide, and they haven't had many side effects. So it's very individualized.
Okay. Can I actually ask one more question?
Yes.
And then we'll wrap up. Okay. So someone, and I think this is more of just like a bigger conversation, but if you two have any comments on this, but this person says, also curious about the impacts of people having mood improvements due to experiencing less anti-weight bias when they're on the drug. But then what happens when they have to go off of it because of adverse events that are, you know, all these things that we're speaking about. Just what happens then?
That's a big conversation.
I know, I'm like, we could have a whole
No,
presentation.
that's
just
okay.
for
That's
that.
okay. But because it's
Good.
important, you know, I think, and Sean and I talked about this earlier, of, you know, there are going to be indications for it, and there are going to be times when, you know, it's not going to be the right thing. There are going to be, kind of like any medication, you're going to try one and it's not going to be the right thing, and then you need to pivot and do something else. You know, there are a lot of people who have experienced self-esteem improvements, you know, people who have been body shamed their entire life and are working to improve themselves, or doing it in, you know, hopefully a healthy way, and may experience less stigma, may experience life in a different way and feel really good about that. They may see changes in lots of different areas of their life. They may see changes in, like I mentioned, self-esteem. They may see changes in libido and sex drive because they feel more confident in their body. They may experience, you know, less shame around going out and moving their body. Now, if they have to stop it, then we see that if it's really abrupt, often you see weight gain happen again. There are times now when people are tapering off very slowly and they're not seeing that rebound weight gain. You know, there's lots of different things going on with that right now. You know, and you know, I think there are a lot of questions about, you know, and stigma around, well, you know, if you do this, you're signing up to take this for the rest of your life. And I just want to challenge people in using that phrasing, because if I were to go to the doctor and they say to me, you know, your cholesterol is really high for your health, we think you need to start a statin, I kind of know I'm signing up for that for the rest of my life. It's not for the next 3 months and then I'm going to be done with it. If I have high blood pressure and I need to start taking a medication for that, I kind of know I'm signing up for that for the rest of my life. You know, if I have my thyroid removed, guess what? I'm going to take a thyroid medication every day for the rest of my life. So, you know, that's okay. Some people may need to do that. Now there's a big cost to this one. And if your insurance doesn't cover it, and that's, you know, that's an investment, but I don't want, I don't know. That's one where I'm like, well, yeah, when we take medications, we sign up for them for the rest of our life sometimes. Not always. Antibiotics, no. Take it for 10 days, I'm done. But there are other things that act differently.
Danny, I'd like to share, and if it's okay. So
Yeah.
it's really, this is a case that was Chrissy was somebody we worked with, and she came to us. She lived in a larger body. It was really there was night eating syndrome that was happening, and really resistant to any awareness, any interoception of their experience, whether it be with movement and whatnot. They had a history in the military where they were degraded because of their body shape and size and whatnot. And main thing that I wanted to share with this is that this person, for this question, I think this, with this question of like, okay, what happens? Well, this person was in our care, never in eating disorder treatment care before, worked through a lot of different circumstances, and even while in treatment had some familial family things that happened that were pretty triggering, and she was able to have a team alongside for the ride with that. She finished program successfully, and afterwards got put on a GLP-1 from her physician. There was success with that. However, what she shared was that if she hadn't done the work, and I think something might have happened, and Chrissy, I don't remember if the Medicaid, like if insurance cut out or something, like with
There
the
was some,
medication.
she ended up having to stop it.
Right.
So she lost weight, and then she did gain some of the weight back also after stopping it.
But she said, and the reason I say but is because what's at the heart of that? And I know we're talking about self-esteem, right? Like, and that's why this is a very complicated, like I think we could have a really rich conversation about it. And I think we need to highlight the fact of, okay, if those things are happening, like what are the upstream effects that are going on? So specifically like with treatment, she was able to have resilience with the changes that happened, and with that work that she had done on body neutrality. I'm not going to say body acceptance, because I know that that's, we could have a whole talk on that too, or body positivity, but that body neutrality of like, okay, wait, where are my values coming back from? I just wanted to share that because I think it shows that, like, whoever asked that question, if you know people on it, they're not alone, you're not alone. There's hope, and that there are ways to get through it, and we don't have to conform regardless of how much society keeps feeding us this message. And even now we have pills, well, not, excuse me, injections. There are some oral ones out there too, but injections that are making these promises to us as well.
Thank you both so much. And someone said, thank you, Chrissy, for saying the rest of your life, that was brought to tears just by your last comment about how powerful that was to hear. So thank you both. This was amazing. Thank you for everyone who spent time with us this evening. Again, please reach out, questions, anything that you want to keep chatting about. But we couldn't be more grateful. So thank you so much.
Thank you, everyone.
Thank you for
Our pleasure to
spending
be
time
here.
with us. Yeah, thank you for spending time with us.